Alright guys, so today we're talking about shoulders. So we'll just go over a little bit of the anatomy first. Some of this might be pretty obvious and repetitive to you, but we're just going to go over all of it. So this is humerus, this is your upper arm bone, this is your shoulder blade, collarbone. So if you're looking, it's kind of set up right here with your shoulder blade in the back, arm going down the side, and then collarbone kind of coming over the front end. So there's actually two joints here we should be thinking about. There's the glenohumeral joint, so it's the humerus, glenoid cavity. So where those two kind of articulate, that's your glenohumeral joint. And then the other joint is the acromion process of the scapula, where that meets the clavicle. That's the acromioclavicular joint. So there's two different joints, so there's a couple different injuries that could impact either of those. Other muscles of note, here's kind of the long head of your bicep tendon. So if you think about that, that'll continue down over the front of the arm. That helps in elbow flexion and shoulder flexion as well. And then we got, so none of the muscles are really obvious here. They're in my other model, but the other model is falling apart. But you got your four rotator cuff muscles. So in this superior fossa, that's where the supraspinatus starts and kind of comes in over the shoulder joint and attaches to the head of the humerus. Then you got your subscap. That's going to be on the inside of your scapula, so between kind of your rib cage and your scapula. And then that also comes across and attaches to the head of humerus. And then you got infraspinatus, which sits on the back of your scapula, comes across, attaches same spot. And then your teres minor basically does the same kind of thing as the infraspinatus. So that just shows you there's a lot of different muscles and ligaments kind of in a small space. So throughout this whole talk, I want you to kind of think about different kind of trends that you'll see in the different injuries, and then so this, because there's kind of the same PT interventions as Eric will talk about that kind of go with all of them. And it's, as far as shoulder health and prevention, a lot of similarities. So I just want to go over a few different kind of injuries that we see that are common in the clinic. Just so you can kind of spot the similarities, the differences, have a little bit of context to know what they are. So the first one we're talking about acromioclavicular joint injuries. So as that second joint I pointed out, it's where the acromion process of the scapula and the clavicle join. There's four ligaments there. Those can be stressed and injured. That can either be due to a fall, due to stress and overuse. You find that a lot of guys are hammering out push-ups and kind of getting one-sided, a lot of overhead activities. Frozen shoulder, that's when the shoulder joint itself, or the shoulder capsule I should say, so all the ligaments and everything that's kind of attaching the the humerus, the head of the humerus into the glenoid fossa, there's all these ligaments that kind of encapsulate it. When there's scar tissue that builds up in that cavity, and these ligaments become very stiff, it's hard to kind of move. That's what we call frozen shoulder. Adhesive capsulitis is like the real name. There's a little bit of debate of what is the cause of that. Some of the things up for debate as the cause are inflammation. It could be an autoimmune thing. It could be a reaction to injury or surgery. If you have some kind of injury or surgery and you're not moving the shoulder as much, that scar tissue can kind of develop and your shoulder literally kind of gets frozen. And there's a lot of other kind of contributing factors, like if you have biceps tendonitis or rotator cuff tear, and you're less likely to move your shoulder, that's when that's going to happen. All right, next thing, biceps tendonitis. We already looked at the biceps tendon. So the biceps, two heads, this is the long head. You can see it kind of comes up and over the humeral head and into the fossa. So there's not a lot of extra room for that. So it's kind of a thin tendon that has lift a heavy load, and it's going through a small space. So that can easily be overused. That becomes inflamed. That's what's going to develop your tendonitis. This is kind of the same risk factors. Doing a lot of overhead, a lot of strain, starting a workout routine that you're not used to. So jumping up in intensity. If you have a job that requires a lot of overhead movement, if you're a pitcher or a throwing sport, all similar kind of mechanisms of injury. Osteoarthritis of the shoulder. That one is less clear of like the actual cause of it, but what we do know is it's the cartilage that kind of wears away in the joint. That cartilage is kind of like the protective mechanism between the bones. So when that wears away, more bone and bone kind of build on each other. You can also through that rough kind of articular rubbing, you can develop bone spurs, which are just going to make the problem worse. You get more bone in a place where bones are already rubbing on each other, and so and a lot of other things can kind of contribute to that. So 90% of the people with that have rotator cuff issues. So there's a lot of kind of overlap with things. This is more something that's going to develop over time. This is more your older person, not typically the younger athlete getting injured in their sport. Rotator cuff tear. So we went over the 4 muscles of the rotator cuff. This is more the younger person, the athletic person. Not that an old person can't have this injury, we see it all the time. That's a little bit more of the wear and tear end. But the younger athlete, falling, pitching too much, you see that a lot with Major League Baseball players that throw a ton and throw hard. That's a lot of stress on those joints that are or the muscles that are meant to stabilize that shoulder joint. So you can have a full thickness tear, that means it's all the way through one of the rotator cuff muscles. Partial thickness, so that the kind of telltale signs for rotator cuff muscle tear are pain on the outside or on top of the shoulder weakness, and loss of shoulder motion. Because if it hurts, you're not going to move it. Shoulder impingement, it's kind of a group of things. So basically, if you think of how limited space you have in here, there's a lot of muscles kind of going right over that humeral head, and to move, there's not a lot of movement. So the rotator cuff muscles, their big goal is to kind of keep the humeral head depressed down out of the way of the acromion. Because for every 2 degrees that the humerus moves, the scapular has to move 1 degree with it. But if it's getting bear down, or this humerus doesn't get depressed before it goes, it'll run right into that acromion and impinge a lot of the things. So that's another way that a lot of rotator cuff tears and other impingements can occur. And that's another thing, same mechanism of injury. A lot of repetitive overhead movements, a fall on your shoulder. This one can also be caused if you have some kind of abnormal structure, like say, this rides up a little bit higher, there's a little extra bone there, the acromion is a little sharper. That can obviously, you can see how that will change the structure of the joint and make it an impingement more likely. Labral tear. So it's on our poster, but basically, if you can picture, this is a kind of a thin fossa on the shoulder blade. That's where the glenoid, the humeral head wants to sit. There's a little bit of a labrum, basically a lip that kind of holds that basically in place. So when that labrum tears, that's going to cause issues. This is something you'll see more like, your patients will complain of like popping, clunking, catching. That's just like a little lip of the labrum, catching every time you move. And like a lot of the other things, it can happen traumatically by one incident, falling on the shoulder, dislocation, etc. And it could also be a non-traumatic thing, which is kind of an overuse. Use it again and again and again, and the labrum wears down and eventually just tears. This is where we get back to kind of like, what are the common themes? The shoulder joint is asked to go through a wide range of motion, do a lot of things, throw, lift, carry. We use our arms and our shoulders for everything basically in our daily lives. And there's a lot of muscles, ligaments, bones kind of going on, and a lot has to go right for everything to work perfectly. The shoulder blade has to move with the humerus. The humerus has to be depressed down by the rotator cuff muscles. Everything needs to be held in place. Anything goes wrong with that whole mechanism, there's not a lot of extra space in there and we get issues. Other things that attribute to that are poor posture. If you're sitting at a desk all day and you're rounded forward, obviously you can see that's not an efficient manner. Poor movement quality, that's why we have things like FMS and other movement screens that therapists will do to make sure that they're moving effectively. That's when you see people compensate by having their traps up here, they're not moving effectively. They're using the wrong muscles to do the wrong things, and that's when they're going to run into problems. Weak rotator cuff muscles, they're not holding the humerus down, that's when we're going to see impingements and tears. So basically just kind of, Eric's going to cover the strength training exercise part. Just kind of go over some of the PT interventions. A lot of it is range of motion. So after the shoulder hurts, you don't move it a while, it's immobile, it's going to get stiff. You need to get that going again. Different tissues in here get inflamed, get irritated, they're going to swell, they're going to get stiffer. Again, once that all comes down, you got to get the shoulder moving again, and you got to get it moving efficiently. Strength training, you got to strengthen all the muscles, kind of around it. You got to have the whole thing moving efficiently. So rotator cuff muscles aren't doing their job. Your trap isn't trained to be nice and quiet. Your rhomboid isn't working to get you into a good posture. You have overdeveloped pecs, which pulls you into a poor posture the other way. So everything needs to have its proper range of motion, its proper amount of strength, and kind of work in concert. And all that will transition into doing more functional training. So that's basically all I got. And a few things just on the prevention side of things, to kind of educate your patients or clients that you're working with. Things like, modifying their activities so they're doing things correctly, lifting overhead correctly, not lifting, poor body mechanics when they're lifting things way up here, carrying things on their side all day long. Finding ways to modify those activities so they're not hurting themselves. Including the rotator cuff strengthening that Eric's going to talk about in their program. And just stretching, doing the range of motion stuff themselves, like utilizing a foam roller on a lacrosse ball. Not sleeping on your shoulder. It's hard to avoid some activities, like if your job is working overhead, or if your sport is pitching, or you have a contact sport where you may fall on your shoulder. It's hard to avoid those things, but a lot of these prevention things, strengthening range of motion can help you stay nice and safe. Now I'll turn it over to Eric, who's going to talk about all the exercises we do in the clinic.
Thanks, Dave. That was awesome. Good all information on all the anatomy and all that. I'm going to cover all the exercises that you're going to see with each one of these injuries that you would see in performance and Optimus and everything. A lot of them are going to be throughout all of the different injuries. There's going to be a lot of repetitions. So I basically just kind of went through the exercises and addressed which injury they're going to be significantly impacting. The first one I've got here is the pendulum exercises. We've seen these a lot for a lot of the patients. Normally they got a weight or a ball or something like that. It's great for range of motion, for the AC joint injury, frozen shoulder, the labral tear, the osteoarthritis, and the rotator cuff tear. And basically all you're going to do is you're going to lean over either on the end of the plinth or right off to the side here, supporting your body weight, and just kind of letting this arm hang loosely. And you can do one of two different things with this. You can either do circles in clockwise and counterclockwise motions, or you can also select a plane of motion and you're going front and back or side to side. Now the thing with the pendulums is that you need to make sure that you're moving in a pain-free range of motion with that patient. You don't want them to try and make these big circles if they're in a lot of pain, because they're obviously it's not going to get them very far. They're going to injuring things further. So they'll start off small with small ranges of motion. Once they get a decent range of motion, they're swinging pretty well, then you can start giving them dumbbells. Start off with maybe a pound, 2 pound, 3 pound. From there, just because you don't want to overload that shoulder, because the weight is just going to add more stress on to the posterior part of the shoulder joints and is going to just cause a lot more stress. The next one is the supine external rotation stretch. That's going to be when I'm laying on the plinth here. And what this is a stretch that you can kind of actually turn into an isometric also. And sometimes you'll see this, a lot of times you'll see it, you'll see this stretch is assisted by the PT. So I'm going to lay it on the plinth here. My arm is going to be at a 90-degree angle here, and I'm just going to gently let it fall back at that 90-degree angle here, so that it will rotate backwards like this, as long as I have comfortable tolerable range of motion. If it hurts at a certain point, then obviously I'm not going to press beyond that, and that's usually where a PT or an assistant, such as an attacker or a trainer, comes into play, because they're rotating this back and they may not be able to go very far. You won't want them to have their arm too far up or too far down, because they're not going to be getting into the AC joint the right way. The next one is going to be the 4-way isometric shoulder presses. What you're going to do, I'm going to take my handy-dandy towel roll, and this is usually placed in a door frame or on a wall in order to do the presses. And if my opposite hand here is a wall, then what I'm doing is that I'm putting pressure in, so my arm is going to be here at a 90-degree angle. I'm going to press into the hardened surface. I think Dave is gonna give me a wall.
Yep.
Dave is going to be my wall. So I got the towel roll here at about torso and mid-torso height here, so that when I come in, I press into the wall, and what that does is that stresses those joints and ligaments in the shoulder. So I'll press in and relax, I'll press in and relax, and then that's one way. Another way is with the elbow. For the reverse, you type in and press in the reverse, and now I'm pressing back into the wall isometrically to kind of work on the opposite side. If I was in a door frame, and I can do it here because I have the movement, for internal and external, I put it in the back of my fist here, close that fist and press outward for the external rotation side, and I can switch this way and peek around the wall here, and I can do internal rotation by pressing internally. And that one's especially good for the AC joint, the rotator cuff tear. You want to make sure that while they're pressing, they're not trying to keep their elbows and stuff away from the body. You want to keep them tucked in nice and tight. Next is a TheraBand, internal and external rotations. Going to be my point. So for your external rotations, again, you're going to have the towel roll is going to go underneath the elbow and pinched into the side. And I know that we all know how to do all these exercises here, but this is just important for us to go over and make sure we're all on the same page here. You want to, for the external rotation, you want to pinch the elbow into the side, because that's going to keep the elbow and the shoulder joint stable, and all they're doing is they're rotating out externally just like this. They're not moving, it's not a huge range of motion, you're not trying to come all the way out here, because now what they're doing is they're stressing their pec minor and even their deltoid, which you don't want to even get into. You want to just have them stay right here in the shoulder area, just like this. For internal, it'll be the same exact starting point. All we're doing here is pulling in. With the internal, you see a lot of people that they think that there has to be some huge range of motion where they need to come all the way across their body. And it doesn't need to go that far. It's a very small range of motion. If you have your patient, your client, really pinching in onto that towel roll, they're only going to find they're only going to be able to go so far before their range of motion is going to end, because they've isolated the shoulder by pinching their elbow in, and they can only go so far through the proper range of motion for that. The next one is the bilateral external rotation. That's basically all we're doing here is holding this here and pinching in and opening up outward. You see a lot of people who start out here and try and come out here like almost like a horizontal abduction, and that works up here as well as the top part of your back into your traps, and you want to kind of avoid that. So you're trying to make sure that they keep that pinch, that 90-degree angle here with the palms up, and just opening up outwards. The ER/IR exercises are good for the AC joint, the frozen shoulder, the rotator cuff, and the shoulder labral tear. Another good one for the AC joint is a TheraBand lateral raise. So you'll be standing on the band, and basically all you're doing is just coming up with the palm down, straight up, making sure that they stay in line with their body. You don't want them way out here or in the back because that's stressing different parts of the shoulder. You want to focus on making sure you get that AC joint by keeping your arm perpendicular with your body, not forward or backward.
Hey, guys. I'm having a really hard time hearing you guys. I don't know if it's the quality of the mic on your end or something, but
Want me to speak up?
is anyone else having a problem?
I'll try and speak a little louder. Do we happen to have a green strap for that strap or no? Right now, readily available. The next one that I'm going to do is the self-assisted, the buddy strap stretch. I think Dave was grabbing me. He's got one for me. So we've got the buddy strap here, and what this is we're going to come behind my back just like this and loop it over my non-affected side shoulder. And what I'm going to do, what you're going to see, is I'm going to pull gently with my non-affected side and just gently stretch out the shoulder. This is good for the frozen shoulder because, as you know, with the frozen shoulder, everything in there is stuck. And focusing on the stretching and the range of motion, I'm going to be able to kind of jar that loose a little bit by doing this exact stretch here. So by coming forward, I can go as far as high as my pain tolerance will allow me to go without having to really worry too much about injuring myself. What else do I got here? Wall slides. Dave, can you give me a wall again, please? So with the wall slides, this is another good one for the frozen shoulder and the labral tear. Again, this is going to be a range of motion exercise that you want to establish a good range of motion. So I'm going to stand close to the wall. I want my forearms to be up on the wall just like this, and all I'm going to do is I'm going to slide straight up. Now the range of motion for this is obviously it's going to be to where it's tolerable. If they can only go so far, then that's absolutely fine. But you want them to keep their elbows in line with their shoulders, so what they're doing is they're not like out too far wide or in too narrow. You want to keep them right at shoulder width with their elbows starting at that 90-degree angle. And they slide up the wall all the way up until they get to a tolerable level. If they can go up as far as they can, then that's fine. You want to stop them, though, right before their elbows start coming off the wall, because at that point they're not really going any further, they're not really doing anything else. You're trying to keep everything nice and intact here, impact. So they come up to about here, and come on back down, and up and down. Yes?
Are you losing any of the benefit if they add resistance and the arms start to just kind of crank in?
If you add resistance, that was a good question. The question was, if we add resistance like a mini band, is there any, say it again?
Loss of benefit.
Any loss of benefit? And the answer is yes, because what you're doing is the normal wall slide is just a typical range of motion. When you add the resistance band, now you're forcing them to ensure that they keep that out here, and what you're doing is you're working on the external part of your shoulder, which
You want to make sure you're externally rotated.
so you're externally rotated and going up. When you come in, all you're doing is you're compensating for that weakness that's in the joint and the tendons that are in the shoulder there. So if you're here and you're able to go up with a resistance band, and all of a sudden it starts to kind of cave in, then that means that you've got that weakness, and you should probably just work on that range of motion first. Make sure you can get all the way up before you start adding resistances, because that's just showing a severe weakness.
And so my number one cue is always wrists wider than the elbows. That's usually the one that kind of makes them understand what they're trying to do.
Another stretch is the cross body reach. This is again good for the frozen shoulder and the labral tear. All this is simple, just kind of come across the body at shoulder height, bring the other arm up and just kind of press in and stretch. it's a good shoulder stretch, and it's also good for your triceps because that's obviously going to run right across, right in. So you kind of have them hold for a good minute or so on each side, kind of get a good stretch out of those shoulders. The doorway pec stretch. This is a good one for again for the frozen shoulder and the labral tear, and I believe the shoulder impingement. So you're going to walk up to an open doorway. I don't know how. All right, so I'm going to do one side of this then. Yeah, I'll get a nice shot of Dave's rear end. So what we've got is I'm going to step up to a doorway. I'm going to place at a 90-degree angle my arm on the outside of the door, and it'll be the same on this side. And I'm going to try and gently step through. And as I step through, my pec major, pec minor, and all the ligaments and everything in the shoulder is going to start to be pressed backwards and stretched. So as I come through the doorway and get a good stretch, I'm just going to kind of hold here. And what this shows, thanks, you can sit down. What this shows is you're going to find the people who have, even if they have a bilateral injury, the one side is obviously going to stretch and flex more than the other because of strength imbalances and stuff like that. So the only way to really cue for this is to make sure that they're keeping their elbows up here, because down here or up here they're just working different parts of the shoulder. You want to kind of keep them getting as much as possible. That 90-degree angle is important because it actually activates most of the tendons and joints in the shoulder. The sleeper stretch. I get to lay down again. The sleeper stretch is good for the biceps tendonitis. You're going to have the patient or client lay directly on the affected shoulder. If they're here, if they're not on it or too far forward, they're not going to get the range of motion is going to be too easy. So I can sit here. If I'm off the shoulder joint, I'm pressing down and not getting any stretch at all. When all of a sudden I pin that shoulder to the table with my body weight, now as I press down with my other hand, I'm getting all kinds of stretching in that shoulder joint. As I come back up, I can only go so far. I saw a hand raised. You guys good over there? All right, moving on. I need you again. Standing, doing standing 90-degree ER and IR. So what this is you're going to be up shoulder height. So with the 90 ER IR, this is another external internal rotation exercise. You want the band to be at about shoulder height. So when they rotate through, you're isolated here. You want to keep this elbow up and in line with the shoulder the entire time. A lot of times what you see is when doing this exercise is when they start to rotate back, they've got that shoulder weakness and the elbow starts to dip. And you want to, if that elbow starts to dip, then you need to decrease the resistance or decrease the weight that they're using if you're using a cable column or anything like that. The key is to keep that up here at that 90-degree angle and rotate all the way back through to in line with your shoulder. You don't have to rotate and go backwards because there's no added benefit to extending further beyond 90 degrees. So we're starting at 90 and we're ending at 90. And the same thing with the internal. I start at that 90-90, keep my elbow up, and I'm just rotating forward without letting that elbow dip. Again, just the same thing with the external rotation. If that elbow is dipping, then that shows a weakness on that side of the joint, and you need to make sure that you decrease the resistance properly to accommodate that weakness. That 90-90 ER/IR is good for the biceps tendonitis, the rotator cuff injury, and the shoulder impingement. I can't do TRX rows in here because I don't have a TRX thing. You want to be my TRX?
I don't know how.
I don't know how you do that either. So moving on. So we've got the single arm shoulder flexion is just a standard, basically a standard forward raise, and this is going to be good for your frozen shoulder and your AC joint because this is just working through range of motion. All we're doing is you're coming up to about shoulder height and coming back down. Once they get comfortable with that range of motion, you can add weight up to a certain amount, maybe 10, 15 pounds, and then to go even farther, because a lot of these shoulder injuries are due to overhead injury, overhead use, you can start from this 90 degrees perpendicular to your body and go up into full flexion rather than just kind of stopping halfway, because a full flexion is starting from here and going all the way to 180 rather than stopping at 90. So if you get them to a point where this is easy, you can increase that angle each and every time they go into the exercise until they've got that full range of motion, a full 180 degrees. I think that's all I've got. Scap squeezes. And a lot of things that you see, we do the scapular squeezes with the rows and extensions. So with a good scapular squeeze, with any exercise, is going to be just movement of the shoulders. You keep the shoulders put down and relaxed. My traps and everything up here are all relaxed. And all I'm doing is I'm just kind of pinching the shoulder blades behind, just like this, is kind of just pinching and rolling my shoulders back and pinching. That's very, very hard to do for people that haven't done this before. And what you end up seeing is when they're coming back for their rows or their extensions, they hike their shoulders up because their traps are overdeveloped and their scapular muscles are not developed enough. And so the rows and the extensions and even just regular scapular pinching is very important to help develop and re-strengthen and regain a balance in those muscles. And I believe that's all I have as far as all the exercises go. So I guess Dave and I are going to open up the floor. Do you guys have any questions or anything else that you guys wanted us to go over?
Crickets.
And